Welcome to the session on management of drug-resistant TB. We will have two sessions under this heading, and I am Dr. Bhanureka, scientist at the National Institute for Research in Tuberculosis. Before going to the management per se, it is important that we know about the different types of drug resistance, since management of patients vary according to the type of resistance. What is monodrug resistance? Resistance to one first-line anti-TB drug is known as monodrug resistant. You must have heard in previous lectures about the first-line and second-line anti-TB drugs. So, in case of resistance to one of the first-line anti-TB drugs, it is known as monodrug resistant TB. More than first-line anti-TB drug resistance other than both isoniazid and rifampicin is known as polydrug resistant tuberculosis. Multi-drug resistant TB or MDR-TB is referred to when there is resistance to isoniazid and rifampicin with or without resistance to other first-line anti-TB drugs. Rifampicin resistance refers to resistance to rifampicin with or without resistance to other anti-TB drugs. Extensive drug resistance or XDR-TB is resistance to isoniazid plus rifampicin plus to any fluoroquinolone, which may be ofloxacin, levofloxacin or moxifloxacin, and to any second line injectable, which includes amikacin, capreomycin or kanamycin. Pre-XDR-TB refers to resistance to isoniazid plus rifampicin plus a fluoroquinolone or a second line injectable. Please remember that drug resistant TB is a laboratory based diagnosis, and drug susceptibility testing have to be obtained from a quality assured laboratory based on RNTCP criteria. Now, let us look at the global burden of drug resistant tuberculosis. Worldwide in 2016, there were about 600,000 MDR and rifampicin resistant tuberculosis cases that were reported. Among the new patients, the multi-drug resistance or rifampicin resistance was 4.1%. New patient refers to those who have never received previous anti-TB treatment or less than 1 month of previous anti-TB treatment. Among previously treated patients, the resistance was 19%. There were about 84,000 MDR-TB cases that were reported from India, and in new patients, MDR-TB was about 2.8% and about 12% in previously treated patients. 6.2% of the MDR-TB patients were XDR-TB, and 20% of MDR-TB patients had any fluoroquinolone resistance, in otherwise known as pre-XDR. Isoniazid resistance was observed in 7.3% of the new patients and 14% of the previously treated patients. The results of the National Anti-TB Drug Resistance Survey done in India in about 4,900 patients, of which 3,000 were new TB patients and 1,800 were previously treated patients, showed that 72% had susceptibility to all anti-TB drugs, 6% had multi-drug resistant TB, in 11.6% among the previously treated TB patients and 2.8% among the new patients. The XDR-TB was 1.3%, 2.3% among new TB patients and less than 1% in previously treated TB patients. Now, before going into the different types of regimens for drug resistant TB, it is important that we know about the classification of anti-TB drugs. The anti-TB drugs that are used for treating drug-resistant TB are divided into 4 groups. The first 3 groups, from group A to group C, are the core anti-TB drugs, and group D are the add-on anti-TB agents. Group A comprises of fluoroquinolones, which are primarily levofloxacin, moxifloxacin. Group B comprises of second-line injectables or the aminoglycosides, which are amikacin, capreomycin, kanamycin, and the group C consists of ethionamide, prothionamide, cycloserine, linezolid and clofazimine. The add-on agents on the group D drugs, D1 consists of pyrazinamide, ethambutol and high-dose INH. D2 are the new anti-TB drugs Bedaquiline and Delamanid, and D3 consists of para-aminosalicylic acid, imipenem, meropenem group of drugs. So, how do we design a regimen with these different group of anti-TB drugs? So, the regimen has to be designed with at least 5 effective anti-TB drugs in the intensive phase, including pyrazinamide, and 4 core second line anti-TB drugs, that is 1 from group A, 1 from group B and at least 2 from group C. If a minimum number of effective drugs cannot be composed, an agent from group D2, that is a new TB drugs, and other agents from group D3 may be added to bring the total to 5. The regimen has to be further strengthened with high dose isoniazid and or ethambutol. The new RNTCP programmatic management of drug resistant TB guidelines was released in late 2017, and this recommends different regimens according to the drug susceptibility profile. So, a shorter regimen of 9 to 11 months duration is recommended for the treatment of rifampicin resistance or multi-drug resistant tuberculosis. So, this regimen is recommended for patients who have MDR or rifampicin resistant TB, which is confirmed by molecular or phenotypic drug susceptibility testing, and they must be susceptible to both fluoroquinolone and second line injectables by the second line probe assay. So, all these drug susceptibility testing and the line probe assay investigations would have been covered in previous lectures on diagnosis of tuberculosis. The exclusion criteria includes previous treatment for more than 1 month with fluoroquinolone or second line injectable with documented resistance, extrapulmonary TB other than pleural effusion or lymph node TB, and pregnancy. So, what is the regimen? So, the regimen consists of an intensive phase of 6 to 9 months duration. So, the drugs are kanamycin, high dose moxifloxacin, clofazimine, pyrazinamide, ethambutol, ethionamide and high dose isoniazid. The continuation phase is for a 5 months duration. This consists of moxifloxacin high dose, clofazimine, pyrazinamide and ethambutol. If the kanamycin has to be extended beyond 4 months, it has to be given thrice weekly. So, all these drugs for the entire duration of 9 to 11 months have to be given daily. So, shorter MDR-TB regimens is also recommended for children and those with and TB patients who are HIV positive. The recommendation comes from published data in nearly 1,000 patients from observational studies done in 9 countries of sub-Saharan Africa, Bangladesh, Uzbekistan, Swaziland, Cameroon and Niger. The patients treated with this shorter duration regimen had higher treatment success rates than those treated with the conventional longer duration regimen. It was 89% versus 78%. So, what do we do for patients who are not eligible for the shorter MDR regimen? Patients ineligible for shorter MDR-TB regimen, which include pregnant women, extrapulmonary TB other than pleural effusion or lymph node TB, are treated by the conventional MDR-TB regimen of 24 to 27 months duration. This consists of an intensive phase of 6 to 9 months duration with kanamycin, levofloxacin, ethionamide, cycloserine, ethambutol, pyrazinamide, and the continuation phase without the injectable and pyrazinamide. So, the continuation phase is for 18 months duration, and the drugs in the continuation phase are levofloxacin, ethionamide, cycloserine and ethambutol. The new TB drug Bedaquiline was approved for anti-TB treatment nearly after 40 years after discovery of rifampicin. This is a diryl quinoline that targets mycobacterial ATP synthase. It has got bactericidal and sterilizing activity against Mycobacterium tuberculosis, and studies have shown that it causes significant improvement in time to culture conversion in multi-drug resistant tuberculosis. So, Bedaquiline in the treatment of drug-resistant TB, initially this drug was used via the Conditional Access Program under the RNTCP in 2016 in 6 states across the country. Now, the drug is recommended for the treatment of drug-resistant tuberculosis throughout the country. So, the basic criteria to receive Bedaquiline should be that the patient must be an adult with pulmonary MDR-TB. The additional requirements include females should not be pregnant and willing to practice birth control methods during treatment, or they should have been postmenopausal for the past 2 years. Patients with controlled stable arrhythmia should be considered after cardiac consultation. So, what are the indications for Bedaquiline use? The MDR or rifampicin resistant TB patients who are not eligible for shorter MDR-TB regimen like MDR-TB or rifampicin resistant TB with resistance to any or all fluoroquinolone or to any or all second line injectable drugs, the XDR-TB patients, patients with mixed pattern of drug resistance, treatment failure of MDR-TB along with fluoroquinolone or second line injectable resistance or XDR-TB, and MDR or rifampicin resistant TB patients with extensive pulmonary lesion, advanced disease, and those deemed at high risk for poor treatment outcomes. So, Bedaquiline should be considered as an option in all these group of patients. So, now treatment of MDR-TB with fluoroquinolone resistance. So, the option is either you treat them with a regimen with the new TB drug, that is Bedaquiline, if they are eligible. So, if you are going to consider the option of new TB drug based on the eligibility criteria for Bedaquiline, it has an intensive phase of 6 to 9 months duration with kanamycin, ethionamide, cycloserine, linezolid, clofazimine and pyrazinamide along with 6 months of Bedaquiline. All these drugs are given daily. In the continuation phase, it is for 18 months duration where we give ethionamide, cycloserine, linezolid and clofazimine. Suppose the patient is not eligible for the regimen with new drug, we need to give a regimen without the new drug for this patient, and this has an intensive phase of 6 to 9 months with the drugs kanamycin, moxifloxacin, high dose, ethionamide, cycloserine, linezolid, clofazimine and pyrazinamide. And the continuation phase is for 18 months duration with moxifloxacin high dose, ethionamide, cycloserine, linezolid and clofazimine. So, how do we treat patients with MDR-TB along with second line injectable resistance? If the patient is suitable for the regimen with new drug option, then the intensive phase for 6 to 9 months will consist of capreomycin, levofloxacin, ethionamide, cycloserine, linezolid, clofazimine, pyrazinamide along with 6 months of Bedaquiline. The continuation phase will be given for a duration of 18 months with levofloxacin, ethionamide, cycloserine and linezolid. If the patient is not eligible for the regimen with new drug, the regimen without new TB drug will include an intensive phase of 6 to 9 months with capreomycin, levofloxacin, ethionamide, cycloserine, linezolid, clofazimine and pyrazinamide, and a continuation phase of 18 months with levofloxacin, ethionamide, cycloserine and linezolid. So, all these drugs have to be given for daily for the entire treatment duration. How do you treat a patient with XDR-TB? So, the regimen with new drug Bedaquiline will include an intensive phase of 6 to 9 months with capreomycin, ethionamide, cycloserine, linezolid, clofazimine, ethambutol, pyrazinamide along with 6 months of Bedaquiline. The continuation phase will be for 18 months duration with ethionamide, cycloserine, linezolid, clofazimine and ethambutol. The regimen without the new TB drug will have an intensive phase of 6 to 9 months with the drugs capreomycin, moxifloxacin high dose, ethionamide, cycloserine, linezolid, clofazimine, ethambutol and pyrazinamide. Continuation phase of 18 months with moxi high dose, ethionamide, cycloserine, linezolid, clofazimine and ethambutol. So, these drug regimens are designed based on the WHO criteria for designing of regimens for drug resistant tuberculosis. If you have to treat a patient with H mono, poly and mixed pattern drug resistant tuberculosis, this chart shows the different types of regimen both in the drugs comprising in the intensive phase and in the continuation phase. H resistant tuberculosis. So, we saw in our initial slides about the burden that it is about 7% in new patients and 14% in previously treated patients. So, these patients are treated with a 9 to 12 month regimen. So, the initial intensive phase can be for 3 to 6 months with kanamycin, levofloxacin, rifampicin, ethambutol and pyrazinamide, a continuation phase of 6 months with levofloxacin, rifampicin, ethambutol and pyrazinamide. Patients with mixed pattern of drug resistant tuberculosis can be treated with capreomycin, ethionamide, linezolid, rifampicin, ethambutol and pyrazinamide, and a continuation phase of 6 months with ethionamide, linezolid, rifampicin, ethambutol and pyrazinamide. If the patient has MDR, rifampicin resistant TB plus fluoroquinolone or second line injectable resistance or linezolid resistance or resistance to more drugs, modified XDR-TB regimen with or without new TB drug based on drug susceptibility tests should be designed for them. So, this chart shows the dosage of anti-TB drugs used for treating drug resistant tuberculosis. So, there is 4 different weight bands based on which the drug dosage is available: 16 to 29 kilogram, 30 to 45 kilogram, 46 to 70 kilogram and more than 70 kilogram. So, based on the weight band, the dosage of the drugs will vary. So, in case of second line injectable, if the patient is aged more than 60 years, the second line injectable should be 10 milligram per kilogram daily to a maximum of about 750 milligram. So, drugs like levofloxacin, moxifloxacin and moxi high dose ethionamide can be given in 2 divided doses in case of intolerance. This chart again shows the drugs that are used for treating the drug resistant tuberculosis like cycloserine, PAS, linezolid, clofazimine and amoxicillin, the dosages according to the different type of weight bands. So, pyridoxine is usually given along with the drugs used to treat drug resistant tuberculosis to avoid peripheral neuropathy, which is a side effect of certain drugs like isoniazid and linezolid. So, what is the dosage of bedaquiline? So, bedaquiline is given for a duration of 24 weeks or 6 months. For the first 2 weeks, the dosage is 400 milligram daily along with the optimized background regimen. From week 3 to 24, it is 200 milligram thrice weekly. From the 25th week to the end of treatment, the background regimen alone is continued. So, this dosage of bedaquiline is across all weight bands, unlike the other anti-TB drugs which vary according to the 4 different weight bands. The CYP3A4 inhibitors like the azole group of drugs which include ketoconazole, fluconazole, or the inducers which include phenytoin, phenobarbital or statins which are the cholesterol lowering agents have to be avoided during the bedaquiline dosage of 6 months duration and up to 1 month after the last dose of the drug to avoid potential drug-drug interactions. This chart shows the dosage of drugs for pediatric TB patients. So, we are going to use the second line drugs for pediatric TB. The milligram per kilogram body weight as suggested in this chart has to be prescribed. So, aminoglycosides like kanamycin and capreomycin are prescribed in a dosage of 15 to 30 milligram per kilogram body weight. The quinolones, levofloxacin and moxifloxacin are given here. Moxifloxacin dosage is 7.5 to 10 milligram per kilogram body weight. Ethionamide is 15 to 20 milligram per kilogram body weight. Cycloserine 10 to 20 milligram per kilogram. Pyrazinamide is 30 to 40 milligram per kilogram. Ethambutol 15 to 25 milligram per kilogram. And clofazimine is 1 milligram per kilogram. Linezolid is 10 milligram per kilogram with a maximum dose of 600 milligram per day along with pyridoxine. So, we need to do additional drug susceptibility testing in patients who are diagnosed with rifampicin resistance or multi-drug resistant tuberculosis. All MDR-TB isolates should be subjected to line probe assay for second line drugs, which include the aminoglycoside and the fluoroquinolone. In case of resistance in second line probe assay, extended drug susceptibility testing by liquid culture for moxifloxacin, kanamycin and cipromycin and linezolid has to be done. In case of additional resistance which are identified with this drug susceptibility test, appropriate treatment modifications have to be done for this patient. So, this flow chart summarizes the different treatment regimens that are used for treating drug resistant tuberculosis patients. So, this chart you would have already seen in the lecture on approach to TB diagnosis. Now, if you focus on the middle lower part of this chart, you can see that if the patient after getting a CB-NAT test, if they are diagnosed with rifampicin resistant tuberculosis, you initiate them based on eligibility criteria to a shorter or conventional MDR-TB regimen, and then this patient is subjected for second line probe assay test. After the test results, if the fluoroquinolone and second line injectable is sensitive, the patient has to be continued on the shorter or the conventional MDR regimen. If fluoroquinolone or second line injectable resistance is observed, then they should be evaluated for new TB drugs and DST guided treatment. If the patient on CB-NAT has got rifampicin sensitive tuberculosis, they should be started on first line anti-TB treatment and they should be tested for line probe assay for resistance to first line drugs, which include isoniazid and rifampicin. And if the isoniazid shows resistant, then the regimen has to be modified for as pertaining to H mono and poly resistant tuberculosis. If the isoniazid comes sensitive, then we have to continue the first line anti-TB treatment. So, in case of additional resistance or failing regimen or drug intolerance or returning after loss to treatment or emergence of any exclusion criteria, then in that case newer drugs and DST guided treatment have to be considered in those patients. So, we talked about Bedaquiline. So, Delamanid is another new drug that has been approved for anti-TB use and granted the conditional access program under RNTCP. It is a nitroimidazole which targets the bacterial cell wall. Its mechanism of action is bactericidal. It blocks the synthesis of mycolic acid and it also poisons the bacteria with nitric oxide, which the drugs release when they are metabolized. The Delamanid is introduced in 7 states in India in 2018. The basic criteria for receiving Delamanid is the patient must be an adult with pulmonary MDR-TB and not eligible for shorter MDR-TB regimen. We saw the indications for use of Bedaquiline. Similar indications apply to Delamanid also. However, special caution has to be exercised in patients with who are HIV positive, more than 65 years of age, those with diabetes, those with hepatic or severe renal impairment, with serum albumin less than 2.8 gram per deciliter, or those who use alcohol or substances. So, Delamanid is given in combination with an optimized background regimen. The dosage of Delamanid is 100 milligram BD for 6 months along with the optimized background regimen. So, with this we end the first session on drug resistant tuberculosis, where we saw the different type of drugs and the regimens for different type of drug resistance. Thank you for your attention.